So, hi everyone. I'm here with Dr. Guy Ringler of California Fertility Partners, and he has graciously agreed to give us a little ERA cycle 101. I know we get a lot of questions about what it is, why people should do it. So we're going to find out from an expert. So, Dr. Ringler, can you tell us what an ERA cycle is and sort of why they originated?
Sure. So the ERA stands for Endometrial Receptivity Assay, and we're really we're making an assessment of how receptive the uterine lining is on the planned day of an embryo transfer. But I'd like to back up a little bit just to review a little bit what happened during the menstrual cycle to the uterine lining. So in the first 2 weeks of the menstrual cycle, the ovaries are making essentially one hormone, estrogen. And estrogen stimulates the growth of the endometrial lining. And as many of you know, we always focus in on the thickness of the uterine lining and the pattern at mid-cycle, because that's when the lining should be maximally developed. And we're always looking for a lining somewhere between 7 millimeters at the low end to about 12 millimeters at the high end. And in the second phase of the menstrual cycle, after ovulation, estrogen falls roughly in half, and we see a large increase in progesterone. And progesterone's role is to make that thickened endometrial lining receptive for embryo attachment and implantation. And over the last 10 to 20 years in IVF, there have been a lot of changes and advancements, all to try to increase pregnancy rates, to improve successful outcome. We focused on laboratory culture systems to try to make a better environment for embryos. We have improved embryo assessment through growing embryos longer in culture and visualizing and grading the embryos. And in the last 5 years, of course, pre-implantation genetic testing of embryos so we can screen out the chromosomally abnormal embryos. The one missing link for many years has been the window of implantation. And the window of implantation refers to the timing in the menstrual cycle when the uterine lining is receptive to embryo attachment. Because if you put an embryo in the uterus in the middle of the estrogen phase, it won't attach. If you put it in after 10 days of progesterone, it won't attach. It really has to be in this defined window when the lining is receptive. Several years ago, most programs quit doing fresh embryo transfers in replace of frozen embryo transfers, because in a frozen embryo transfer, we can better define when we're putting that embryo in with respect to the window of implantation. And in IVF in general, it's thought that about 25 to 30% of failed transfer cycles are due to a displacement of the window of implantation. Up to 2/3 of failed cycles are due to embryo issues. 1/3 are due to uterine issues. Many of them due to a displacement of the window of implantation. We're putting the embryo into the uterine environment at a time when the lining's not optimally receptive. So getting back to the ERA test, a group in Spain at IVI, if you're familiar, Dr. Carlos Simon developed, they've been studying this window of implantation, and they looked at the expression of genes that are turned on at that time period. Because one of the hypotheses for embryo attachment has been that the uterine lining has expressed proteins, like an attachment protein, so like a Velcro strip that becomes visible during that window of implantation that the embryo can latch onto. So, well, these attachment proteins are made by RNA. RNA is expressed by genes that are turned on. So they looked at which genes in the uterine lining tissue are turned on during this window of implantation. They've identified 258 genes that are turned on. And then they began looking at patients with multiple IVF failures, and they compared when the genes were turned on in those cases versus normal patients, and they found a displacement. So to possibly explain why patients weren't getting pregnant. And they found that these changes were not irreversible problems, but they could be corrected by changing the timing of progesterone. And so now the endometrial receptivity assay is based upon the expression of these proteins in relation to the number of hours of exposure to progesterone. So our standard protocol, patients are on estrogen for usually anywhere from 12 to 16 days, and we start progesterone. On the 6th day of progesterone, we thaw and transfer the embryo. And for most patients, the number of hours of progesterone exposure that's ideal is about 125, 128 hours of progesterone. So the endometrial receptivity assay is going to tell us if that number of hours of progesterone is putting us in the middle of the window of implantation when the lining really should be optimally receptive. So in this assay, we prepare for as if we're going to do a frozen embryo transfer, estrogen for 2 weeks, add in progesterone. We tell them specifically what time to start the progesterone, and we look at what time we do the biopsy, and the assay is going to tell us whether or not we have a receptive lining. And they will tell us if we are receptive or we are pre-receptive, meaning we need additional exposure to progesterone, or we're post-receptive. We have too much progesterone exposure. And so by changing, if we have an abnormal result, meaning we're not receptive, by making their changes, we should be able to significantly increase the pregnancy rates. So they recently published a 5-year randomized study. There have been multiple other studies, but this is the largest one with about 450 patients. And they showed that they could increase the pregnancy rates by doing an ERA cycle before the embryo transfer. So they call this a personalized embryo transfer. A personalized embryo transfer is an embryo transfer after having performed an ERA to fine-tune the progesterone exposure. Just to give you a little visual, so they showed that the live birth rate, Erica, you can tell me if the visual's helping or not.
No, you're great. You're great. I can see it. Yeah, I can see the wheel.
Okay, I'll try to hold it and then I'll just read it.
Yeah, if you go a little higher for me. There we go. Yeah.
Okay. So the pregnancy rate using the personalized embryo transfer increased 18% in frozen embryo transfers. The live birth rate increased 13.8% in frozen embryo transfers. So by performing the mock cycle prior to the actual transfer, we're able to make a significant increase in pregnancy rate without doing multiple transfers. Now, these are in patients with history of infertility, okay? We deal with surrogates. So with surrogates, we assume everything's normal because they've had proven fertility.
Hey, Guy, your video disappeared, which is fine. I can hear you, but I can't see you for all of a sudden.
Oh.
There you go. You're coming back.
Okay.
You're back.
So the concept is that the endometrial receptivity assay allows us to fine-tune the protocol to make sure that using our standard timing that we're placing the surrogate's uterus in the middle of her window of implantation. Now, this study I just talked about dealt with patients with infertility. Surrogates have proven fertility. So do these same numbers apply? We don't really know. I'm going to pull some of our numbers here to see if we can replicate this. So what I've been doing, my partners have been doing in patients with very few normal embryos, we will do a ERA mock cycle first just to make sure the timing is perfect. If patients have a lot of normal embryos, oftentimes I'll just do a transfer first. If it works, fantastic. If we have 1 or 2 failures at that point, go back and do the endometrial receptivity assay. So it gives us helpful information to fine-tune the implantation window for the patient. So I think the question for surrogacy cycles is when to offer this to patients. Do we offer it from the beginning? The only downside is added cost, really.
Mm-hmm.
It's 3 weeks, 2 weeks of estrogen, 6 days of progesterone, and a biopsy. But it does give very helpful information, I believe.
Is the biopsy procedure itself just a quick inpatient? Is there anesthesia, or it's just sort of like an embryo transfer, similar sort of experience for the surrogate?
Yeah, it's more like pap smear embryo transfer. No anesthesia is required. Literally, I insert a speculum, clean off the cervix. The catheter is a little bit wider, of course, in an embryo transfer catheter. It's like a straw, a narrow straw. I pass it cervix into the uterus, and as I pull back, it takes a little piece of tissue in the uterine lining. You may feel a menstrual cramp. Some patients feel nothing. And it really takes about 2 minutes to perform.
Okay.
And at that point, she stops all her hormones, she gets a period, and we can roll right into a transfer cycle if we want, or we could wait a cycle. Usually takes about to get the results back.
Okay, so if you get a result where you're like pre-optimal or post-optimal, do you do another ERA cycle, or does that give you enough data to adjust meds?
Yeah, it'll tell us how many hours will make her optimal.
Cool.
So it
tells
me how to make a change. You know, if you are really really an outlier, they may ask you to repeat it. But back 3 or 4 years ago, they used to do that more often. Today, they rarely do that. So usually they make recommendation on how to change the protocol.
Okay. So really the only way a surrogate would fail an ERA cycle is if her lining didn't develop to an optimal thickness. Is that a reason why you would maybe start over on a different medical protocol, or?
Yeah, usually if her lining is not optimal, I'll just cancel the ERA because this may not give me the best results. I've repeated a couple of ERAs that didn't make sense. I had one surrogate where it told me it was pre-receptive. I made the changes, and then they told me it was post-receptive, and ultimately turned out she had made errors in her progesterone administration. So,
okay. Is there ever an instance where you would advise against an ERA cycle? I'm not really hearing a reason to not do it except for like time and cost.
You know, some intended parents are impatient. They want to get going.
Yeah,
you know,
there's that time question.
They have a large number of euploid embryos. You know, transferring a genetically screened embryo into a surrogate, you know, positive pregnancy test is just under 80%, delivery rate between 65 and 70%, single embryos is pretty high. So, you know, the big question, do we have to do this? And how much higher can we get by doing this? You know, we'll boost it, you know, 5 to 10%, at least. So,
yeah.
I would love to do it in all my patients because you know, we're all about wanting to give our patients the highest success rates.
Yeah.
And this can fine tune one variable, you know, the time of progesterone. So we know there's no issue. So
yeah. Well, look, one of the things I always say to clients is if you do an ERA cycle and you get pregnant, you're not going to look back and be upset that you did the ERA cycle. But if you don't do it and you're not pregnant, you might look back and have regret. So I sort of tell people, think about it like out from the future and look back and, you know, assess what you think. But it seems to be a pretty good argument for doing it, and it's minimally invasive. I'm not sure that you're the right person to ask this question of, but approximate cost with meds and the procedure itself?
Yeah, no, I was just going to say we should really calculate the cost. I know it's between $3,000 and $4,000.
Okay.
When you add the blood test, medication, ultrasounds, the assay itself is about $700 from the company.
Okay.
And you know, I'm happy to work with my billing office to see maybe what blood tests are absolutely necessary, which we can eliminate if we need to make a more streamlined cost protocol.
Okay. Do any of the IVF packages your office does, do they just include ERA cycles, or is it always an add-on? Yeah. Okay. Okay. All right, cool. Well, I think we covered all of the questions that I've heard about this procedure and that I thought of since we started talking. Is there anything else you think we need to know about it before we say goodbye?
I think this about covers it. I'm open for questions.
Cool.
Anyone send me an email if they have any questions that come up. And,
All right.
we should talk again about it. I mean, who to offer it to, if you want to offer it to everyone, it would be fantastic.
Yeah, I think it's definitely a great option. Like, we have a lot of gay couples where they split embryos between two dads, and then so they were dealing with a more limited set of embryos each. And
Right.
so, like, to me, that's a great opportunity to take advantage of this, or folks who have a finite number of embryos and can't make more. But I would say that if I said to most of our clients for $3,000 to $4,000, you're buying 5 to 10% increase in success rate, I would venture to say most would say yes. Maybe some not, but most.
Yeah. Great.
All right. Well, really appreciate you taking the time. It was good to see you.
Welcome. Glad it was helpful.
Yeah. Thanks.
Bye.
Bye.